And good afternoon, ladies and gentlemen, once again. Many thanks, AIOC, for giving us this wonderful opportunity time and time again to conduct this instruction course. I think it's almost, we are in 10th, 12th year now. So before I begin, let's have a show of hand. How many of us would have dropped intraocular lenses? Yeah, there are quite a few, almost half of all. So let's talk about the principles of management. No financial interest in my talk. But before we begin, the most important thing in this kind of management is a good bimanual anterior vitrectomy. Mind you, this includes toileting of the wound, separating the irrigation and the cutter port. This is very, very important, and always staying in the center of the pupil. You don't have to go and chase the vitreous. Never chase the vitreous. The vitreous will chase you. Okay? It's always reverse. So stay in the pupillary margin, do a good anti-vitrectomy job, thorough toileting of the wound, and if you are not able to implant the intraocular lens, don't drop it inside the vitreous cavity, just leave it at this stage. But there are instances like this surgeon, when he was implanting, he didn't implant only one intraocular lens, he implanted almost 3 intraocular lenses into the eye. So these kind of instances should be avoided. Be aware of the complications. Complications can happen in best of the best hands, but you should know how to manage it. So this kind of disastrous things should be avoided. Sometimes we have done a good phacoemulsification, but a small carelessness on our part when injecting the intraocular lens can tilt the outcome in the other way around, as in this case has happened. The surgeon was not careful and implanted the intraocular lens into the vitreous cavity. So small, carelessness can lead to a big way and should be avoided. Always be careful whenever you have a problem. These are a couple of our residents who are operating. Whenever you have a problem, call for help and immediately don't try to mess it up even further. So always be careful. So what we have devised over a period of time, this was a thought given by Abhay Vasavada sir about 9 to 10 years back. Can we do something different in the steps of anti-vitrectomy? So here we go. What we try to invent here is, or what we try to do, is try to do a pars plana vitrectomy approach rather than doing a limbal approach. It's fairly easy, can be done by any of us who are there in this hall. The only thing is that your direction of instruments goes towards the optic nerve rather than going towards the pupillary margin. And you just have to do a 2-port incisions here. So here in this video we will see that the infusion cannulas here, this is a 25 gauge Alcon based trocar system, but it can be used with, you can use any of the systems which are available. Do a straight entry, it don't have to be an angled entry. And this is a case of a old case of IOL dislocation, but can be done as a primary procedure as well. So what point I want to drive here is, once you have an infusion in place, it can be as showed by Amar Agrawal sir from the from the limbal junction as an AC maintainer, or from the pars plana region. It gives you much more controlled environment. So this is the point what we want to draw here. Once you get a much more controlled environment, the rest of your maneuvers become very easy. The rest of the steps of vitrectomy remains the same. You need to be only in the pupillary center. You don't have to go and chase the vitreous. Use judiciously intraocular intravitreal transdermal acetonide as much as you want, a diluted one, and then just stay in the pupillary center and do the rest of the steps. Here are a couple of instances where we had challenging intraocular lenses removal. One instance is hydrophilic IOLs. Hydrophilic IOLs are very tricky to remove because you don't get a good grasp of it. This patient had a drop of intraocular hydrophilic lens with a capsular bag, and once we have completed a vitrectomy, the most important step here is a good posterior vitreous detachment. Once you have done this with suction assisted technique or even a forceps grasp, you can remove these intraocular lenses quite easily. But you have to be little careful in grasping or getting the first grip of the IOL. If you're not careful, you can cause a macular break or a macular hemorrhage. So as what you see here is a good posterior vitreous detachment with a thorough vitrectomy done for this patient. And then only we touch these intraocular lenses from the surface of the retina and try to remove it off. The rest of the maneuver becomes quite easy. These lenses come out from the limbal section very easily because they are easily malleable. So what I'm trying to do here is getting a good view, a crisp view, and then only grasp these IOLs from the surface of the retina. Once you get a good grasp, removal becomes very, very easy. Now, there are instances where a rigid intraocular lenses they pose a different challenge. This was one of the challenging case where a rigid intraocular lens was lying flat on the, like lying perpendicular to the surface of the retina. So catching these IOLs are becoming, it's little trickier because once the intraocular lens falls on the surface of retina, the haptic itself can cause a further damage to the retina in form of bleeding, tear, and so on. So the important point here is don't free the intraocular lens immediately from the vitreous. Do the vitrectomy in the other quadrants and then come to the intraocular lens in the last. And after freeing the vitreous from the intraocular lens, then only grasp it and remove it. So this was one of the challenges. One of our friend was very overzealous, rather than only staining the entire capsule, stain the entire vitreous along with it, and these kind of things should be avoided. As you can see here, the view is very challenging, and when you don't have a good view, even removing this intraocular lenses become very, very tricky. So these kind of maneuvers should be avoided. In spite of repeated washing of the vitreous from the saline, still the glow of the trypan blue is still there. So all these maneuvers, one should avoid it. Getting other challenges in form of corneal edema, associated inflammation, and so on, where your view becomes hazy. And also if the patient has associated retinal problems, like this patient had a proliferative diabetic retinopathy, along with vitreous hemorrhage and a tractional retinal detachment, and a dropped intraocular lens. Though we have managed it quite successfully, but these are the challenging situations one we can encounter. Induction of the posterior vitreous detachment is the key, whether the view is good or view is not good. So be patient and don't try to mess up these cases further. Refer to your VR colleague. That's a point which I want to drive. In pediatric cases, we have to be very careful. As you can see here, the surgeon has done a beautiful PCCC, but still not very careful or confident while injecting the intraocular lens, and the intraocular lens has been injected into the vitreous cavity. This child was under general anesthesia, and we were called immediately, and we rescued the intraocular lens from the vitreous cavity, did a vitrectomy, and then implanted the same intraocular lens into the sulcus with an optic capture. So sometimes you have to be little vigilant and careful. This was one of the rare cases we published as well. This was a capsular bag with intraocular lens along with the Retisert implant, which we don't implant nowadays, gone inside into the vitreous cavity. The challenge here was not removing the sommering ring, the capsular bag, then the intraocular lens. The main challenge here was to remove this Retisert implant, which was slipping on and off from the retinal surface. But with careful maneuvers and following the basic principles and with a good suction, we were able to improve the Retisert implant as well. Couple of challenging situations as shown by Dr. Sujata, glued IOL with nucleus drop. In this patient, when doing the phacoemulsification with a grade 2 cataract itself, the patient had a nucleus drop. So what we do it differently here is, we first finish the glued IOL. Very beautiful technique invented by Amar sir. So once you have done a good glued IOL here, the rest of the maneuvers become quite easy. You don't have to bother about the rest of the maneuvers because the view becomes very hazy and view becomes very good, and removal of the nucleus from the vitreous cavity is also quite simple. In the interest of time, I will run through my videos. So important point is managing complications should be the forefront for any surgeon who wants to learn surgery, and meticulously, and no dials can get better with the people who are sitting here and who have guided us on the careful assessment and planning of each and every case. Avoid overzealous maneuvers, understanding the principles of management involved, and it's always a teamwork. These are my acknowledgements. Before I conclude, we request all of you to extend your wholehearted support to none other than our Dr. Mohan Rajan sir here. He is a leader, team builder, and visionary par excellence for Vice President 2025 AIOS. And we also extend our warm welcome for all of you to come and be a part of Tamil Nadu Annual Conference, which will be held on 16th, 17th, 18th of August in Chennai this year. Thank you so very much for a patient hearing.
Thank you, Manoj. You covered a very important topic.